how it impacts low-income individuals and communities. And so a little bit about the agenda for today. We're going to be doing kind of a welcome and a little bit of an overview of the Health Intersections Learning Community. Then we're going to hand it over to Angie from the Michigan Department of Health and Human Services. And then we'll follow up with a question and answer session to kind of get you all engaged and talking with each other about the different initiatives you might have going on and any questions you have about how to enhance those initiatives. And then we'll be talking about different tools and resources that we have available for you all. If you haven't joined the other Health Intersections webinars, we do have those recorded, and I can show you where to go to get those. All right, so a little bit about our learning community in case you're not familiar. The basic purpose around this is really to analyze community action outcomes and identify the effective and promising practice models that alleviate the causes and conditions of poverty. So it's really all about building agencies' capacity to be able to fight poverty throughout the nation. And so we have several groups. This is one of about 3 open groups that we have, and then we also have some closed groups, which are some more close-knit groups that require kind of an application. Those participants do a goal plan around their subject area. One example is bundled services, and try to actually implement a pilot of some sort of initiative in their agency in hopes of transformation in some way. So this national webinar series, this is one of the open groups, and it's all around different intersections with health. So the first one we talked about was the social determinants of health, and that was back in April. And then housing was just a few weeks ago in May. And then today we're focusing on substance abuse, like I said. And then in July we'll be talking about food access and nutrition. And so a little bit more about that after the webinar. But that's kind of what's behind us and what's looking in the future. So this webinar or this learning community is a little bit different than some of the previous ones. So we have 4 monthly webinars. So it's a little bit shorter. We've had some learning communities that have been on an 18 to 20 month time span. Then we did a survey to gain some feedback from the initial participants. We're trying out some peer-to-peer learning subgroups after each webinar to kind of give people some time and space to interact with peers and subject matter experts in a more informal conversation, looking at the initiatives in their area and what they can do to kind of enhance or share best practices around those things. We also have resources available via Basecamp, which we do for all of our learning communities, as well as on the blog. And then we'll have kind of a capstone session at the Partnership's annual convention in Philadelphia in August. So this is kind of what the timeline looks like for how we're doing this learning community. So right now we're right here in the middle in June. And we've got a little bit more to go and some good stuff behind us as well. Our Learning Community Resource Center team, LCRC is kind of what we call it for short, is kind of comprised of individuals you see on the screen. So Jarl Crocker, Director of Training Technical Assistance, and then Tiffany Marley is our Project Director. Hyacinth McKinley is our Program Associate. Myself, I'm the Senior Associate with the Community Action Partnership. Working part of my time with the Learning Community Resource Center. And then we also have Liza Porras, who has recently joined our team in a different capacity. She used to work with the Rural Impact folks in that learning community, but now a program associate for the partnership. So happy to have this team together. So as always, we always like to start out our webinars with the promise of community action, just kind of grounding ourselves in the work that is being done and the purpose behind it. So you can kind of say this with me at your desk, but community action changes people's lives, embodies the spirit of hope, improves communities, and makes America a better place to live. We care about the entire community, and we are dedicated to helping people help themselves and each other. So just a little bit of a check-in. If you are having any difficulty with your audio, please enter any comments or trouble that you're having in the chat window. What we've done is we've muted everybody since this is a larger in our event center for WebEx. But towards the end when we get to the Q&A, we can unmute you if you'd like to speak and ask a question or talk about an initiative that you have going on around substance abuse. But otherwise, we'll use the chat function for any questions, comments, or trouble that you might be having with audio. So hopefully everyone can hear me well, and there are no audio issues at this point. All right, so our subject matter expert for today, like I mentioned earlier, we have Angie Smith-Butterwick from the Michigan Department of Community Health, and she's a women's treatment specialist in the Office of Recovery-Oriented Systems of Care. Works on a number of different programs. She's worked with community action agencies in the past, and actually got some of her start in human services working in Head Start. So she's pretty familiar with community action and works with other programs that work alongside community action as well in the state of Michigan. And so at this point, I'll go ahead and turn it over to Angie, and we'll get started in our main content.
And Community Action Agency. Can you guys hear me okay now? Is that right?
Yes, I just unmuted you, so you might, if you said something before, you might start over.
Okay, good morning, everyone. As Courtney mentioned, I did get my start in community action agencies. I worked for Head Start for 6 years in the, what would be, in Michigan at least, a family advocate role, where you are the person who gets all the kids enrolled and kind of makes sure all the family's needs are being met. I also worked for that same agency as an intern in undergrad doing their food program and helping out with weatherization. And as with any agency that's a community action agency, even though I worked technically in Head Start for 6 years, anytime there was a big need within our community, it was kind of an all hands on deck type of situation, and everybody was expected to contribute, do what they could to get things moving and get people involved and doing different projects. And every year in Head Start, we did a different project with our families. Sometimes we would do a community project, like for some of our local nursing homes. Sometimes we would do projects directly related to our classrooms and making them more safe and more user-friendly for the kids, updating different things and that kind of thing. So now I am working almost exclusively in substance use. Of course, it's a constantly changing field, just like with community action. As we do more and more research, we discover that things could be done a little bit better. One of the interesting things that has happened over the past few years is our need and the recognizing the need to work very closely with other systems. When I first started working in my position 11 years ago, we were very siloed, and it was very much an attitude of stay in your own lane. Substance use does substance use. You don't worry about health. You don't worry about mental health. We have gotten much better at working together in past years and much better at blending our funding so that we can provide more services to cover more needs and making sure that all needs are being met. However, one of the things that I have discovered in working more closely with especially the health systems is that amazingly, even though we think that they do, doctors don't know everything. And frequently, if they don't know about a particular subject, especially when it comes to substance use or mental health, they don't want to talk to their patients about it. They are concerned about doing a screening, finding out that somebody has an issue, and then not knowing what to do from there. So we've been working really hard in Michigan to collaborate better, provide referral networks to doctors' offices so that they have a better handle on what they can do as they discover different things about their patient population. One of the things that we have been fairly successful with is called and I need to remember to advance my slides, right, Courtney? Okay. It's called the Michigan Child Collaborative Care Program. This is a program that we do in conjunction with the University of Michigan. We have a shortage of psychiatrists in Michigan, especially in the area of child psychiatry. And at the farther north you move, the more scarce child psychiatrists get. And yet we still have a pretty decent population of children and adolescents and young adults with high levels of need in the area of child psychiatry and mild to moderate behavioral health concerns. In Michigan, we have our population separated for mental health. So if you have a severe mental illness, you would access services through our community mental health service provider organization, and they receive funding that is directly for that severely mentally ill population, and they generally don't have enough funds to serve the mild and moderate population as well. So they're kind of left to the mercy of Medicaid and other funding sources, some of the what we would call local grants and that kind of thing that would support their health. So as I mentioned, the population for the MC3 program includes children, adolescents, young adults through age 26, pregnant and postpartum women, and all of them would have a mild to moderate behavioral health concern. The population also will include a woman who is contemplating pregnancy, and postpartum women are eligible until the child turns 1. So we're specifically trying to focus on those women who would have postpartum depression or potentially have postpartum depression where they wouldn't have any other resource. And as I mentioned, the farther north we get, the more scarce resources get, and the less options doctors have for reaching out to colleagues to find out, okay, I have a patient and I'm not real sure what to do. So this provides an opportunity for a doctor to reach out and to the University of Michigan, and the University of Michigan will provide some guidance as far as diagnoses, medications, how to manage behaviors, what interventions might be good for a patient who's experiencing certain symptoms. And then it helps the doctor better manage the patients in their practices. So then they don't have the people who are getting so far out of control that then they're ending up in the emergency room or the psych hospital as opposed to being able to be managed within the practice. The support they provide is using educational phone consultations with the provider, so with the primary physician, his office staff, and they will also do remote psychiatric evaluations for patients and families through like a video telepsychiatry process. Of course, there's some confidentiality and HIPAA things that go along with that, so they have to be sure that everything is going to be okay on the patient's end, that there isn't going to be any public interaction while they're talking to the patient and the family, that it's a private area and they don't have to worry about anybody overhearing their conversation. The University of Michigan also has some educational modules available on their website for primary care providers, so they can watch those and get kind of a basic education that they wouldn't have received through their regular training. And this project has been going on, I believe, for almost 3 years. We do it through Medicaid. So all of the people who are eligible would be Medicaid eligible clients, and in Michigan we also have Medicaid expansion, so they would be using what we call our Healthy Michigan plan as well. We are just starting a similar service that we're calling the Michigan Opioid Collaborative. Some of you may be aware that through the 21st Century Cures Act, all the states and territories were offered a pretty significant amount of funding to address the opioid epidemic. The vast majority of states and territories applied for and received that money. Michigan was one of them, and we rank about number 6 in opioid overdose deaths. So we got a fairly substantial amount of money, over $16 million per year for 2 years. So one of the outcomes of our grant money is going to be this Michigan Opioid Collaborative, and we're modeling it after the MC3 program. So it's a consultation services that's provided for a physician, and that would be usually through what we call an office-based opioid treatment setting. Those are the physicians that only prescribe Suboxone, or buprenorphine is another word for the medication that you may have heard. It's appropriate for some people, not appropriate for everybody, but a primary care physician can take the classes and become certified to prescribe this medication. Unfortunately, the certification requirements don't include any behavioral health component to go along with that. It's recommended that the patient also be involved in behavioral health care, but it doesn't have to be offered within the office-based opioid treatment setting. And as I mentioned, doctors aren't always really connected with what's going on in their communities, so even though they may have a patient that they're prescribing the Suboxone or buprenorphine for, they don't really know where to send them for the behavioral health therapy, the therapeutic intervention part, the counseling that they would get weekly and in groups and that kind of stuff, so that they can talk to other people with the same issues, and the therapist can kind of guide them through their treatment plan. So through this Michigan Opioid Collaborative, the patient is connected to a behavioral health consultant that is assigned to that county for a needs assessment. The limitation, since we're just starting this, is that we're only going to be providing services in 4 counties down in southeast Michigan that are kind of the surrounding Detroit area. So it would include Ann Arbor, where the University of Michigan is. There's a couple of rural-based, primarily rural counties down there that they'll be serving, and Monroe. Ideally, we'll be able to expand the Michigan Opioid Collaborative to the same counties that are currently serviced by the MC3 project, and that's 50 of the 83 counties in Michigan. One of the ways that we're hoping to engage individuals with an opioid use disorder is by providing that extra education to the primary care doctor, and hopefully we can encourage the ones who have that certification but aren't currently prescribing through this support mechanism to start prescribing to some of the individuals out there. We haven't quite encountered a capacity problem yet, but we know that we have a lot of people out there who need treatment and aren't receiving treatment, and we hope that by encouraging these physicians who aren't currently prescribing and offering the support to them, that we can start to serve more and more people and hopefully reduce the number of deaths that we have in our state. The Michigan Opioid Collaborative is going to do a 2-tier approach, as you can see on the slide. They'll do the consultation by phone. They'll also do the telepsychiatry by phone or video conference. We have some practice guidelines in place in Michigan that identify what an opioid treatment program should look like, and the physicians at U of M will also provide consultation to the primary care physician on what that's going to look like, some of the things that they should be aware of as they're moving through practice, and some ways that they can get some additional information. So step 1, the behavioral health consultant helps to confirm the client has chosen the right treatment approach. And as I mentioned, Suboxone and buprenorphine aren't appropriate for every client. Some clients need methadone. Some clients would be able to use Vivitrol, which completely blocks the opioid receptors, but that's basically for a client who hasn't been using for very long. The vast majority of the people that we encounter actually need the methadone treatment because they've either been using intensely or using for a long period of time, and Suboxone just isn't quite enough to support and mitigate all of their withdrawal symptoms. So we end up funneling them into some of our methadone programs. So the behavioral health consultant will also assist in connecting patients to alternative options for medication-assisted treatment, as I mentioned. So if the Suboxone isn't going to meet their need, they'll connect them with methadone or Vivitrol. In Tier 1, the social worker and clinical psychologist team provide help on needs related to counseling and therapy. The physician team will provide help with the medication and any comorbidities that they may have. The vast majority of our folks with opioid use disorder also have some pretty interesting medical issues that go along with that. And the vast majority of them have not been seeing a doctor regularly. The primary care provider can then follow up with the patient based on what they've learned through the consultations with behavioral health. And in Tier 2, the patient and the family members meet with the U of M team of clinicians by phone or video for further interview and evaluation. The U of M team can then follow up with a primary care provider, and they can provide recommendations based on what they learned in the video conference and the interview with the family. Okay, so some of our challenges with telehealth. And I have to apologize, Michigan is having a high pollen day, and it's affecting my voice. So I have to take some frequent breaks for drinks. Michigan is an interesting state in that the lower half of the Lower Peninsula technology is not really an issue. We have a fair amount of metropolitan areas that are well connected to internet service providers, broadband, really no cell phone issues, that kind of thing. But the farther north we get in the Lower Peninsula and across the Upper Peninsula, we can have some serious technology challenges. Broadband internet is supposed to be available all the way across the Upper Peninsula. However, depending on where you're at, you can experience some challenges. You can lose cell phone service pretty easily. And then just based on the vast amount of snow that they can get up there, they can have problems even getting people in appointments face-to-face and that kind of thing. So sometimes telepsychiatry and telehealth just isn't really even a viable option depending on what the weather can be up there. A lot of our programs have older equipment. You know, you can, when we have been interacting with them and asking, okay, so what type of equipment do you have, as we're looking at what we can do to help with some of the telehealth, they'll still be using Windows XP, which is no longer supported. And we frequently have had to find alternative resources for them to upgrade the equipment. We've worked through Michigan State University Extension Office. They do a lot of community outreach, and I'm sure you probably have universities in your states that do the same. And we've gotten some grants through them to help upgrade some of our rural and northern hospitals so that their technology is at least on par with some of the more metro areas. And then they can help provide some of that telehealth and can connect with other offices to provide some support. So we also have to ensure that as we're interacting with clients and patients via telehealth, that their equipment is up to standards too. Sometimes we've had to provide smartphones so that we can do that. Thankfully, those are getting less and less expensive, and we can program them in such a way that they can only call the therapist or the doctor so that they can't be used by the person for just any random call. And of course, I mentioned confidentiality with the other programs that we're using, and it's true of this one as well, making sure that the spaces that the clients are using are confidential, that nobody else can hear what's being said. And this is especially important as we're doing group work in some of our therapeutic agencies. We have to ensure that not only the client on the receiving end, but the other clients that are participating in this group, that their confidentiality is protected as well. So some client might say, oh, you know, it's okay, my mom's here or my significant other's here. Well, that might be okay for them to hear your information, but it's not okay for them to hear everybody else's information. So we have to make sure that we stress that and remind them that they're not the only person that's going to be sharing and involved in this process. One of the barriers that we encounter fairly frequently is willingness. It's not always easy to find a qualified partner or a willing partner, and finding those two qualities together can be a real challenge. Somebody who's willing and qualified and has the appropriate equipment. So our expert teams have to be technologically capable. They have to have a good understanding of confidentiality related to their scope of practice, whether that's HIPAA or in the SUD world, that's 42 CFR Part 2. And we'll talk a little bit more about that later. So connecting with clients. When I was speaking with Courtney, she mentioned that a lot of you do a lot of work in the community, and that you'll encounter clients that you suspect might have an SUD or that disclose that they have an SUD, and nobody really knows what to do next. Sometimes, especially in Michigan, because we have a fairly high population, we could have some substantial waiting lists. So even though some of our community action partners may know of programs around them, those programs may be full. And without having the next step or that next level referral process, they aren't always able to connect the person to what they need. So one of the biggest things about working with individuals with SUD is having a good understanding of what your own values, beliefs, and stereotypes are. And I encourage everybody, even the programs that I work with, because I work primarily with women's treatment programs, to take a regular inventory of how you're feeling about your clients, what you're thinking in your head when somebody's talking to you, and kind of deconstruct all those different things and see if you're having some of those stereotype issues, or if you're having some of these people are driving me insane kind of issues, because it's the these people part that needs to be addressed. So we have to be able to understand where we're coming from, where our feelings are coming from, and make sure that that's not coming out in how we're interacting with our clients. That's also kind of feeds into the whole belief about SUD being a behavior problem. And unfortunately, mental health and SUD have been classified under behavioral health, even though they're both valid medical problems and have been identified as medical models. The perception still remains that this is a behavior, and that kind of implies a choice. So somebody is choosing to use this drug, is choosing to be an addict, is choosing not to get healthy, not to be in recovery. They choose the relapse. They choose not to take their medication, that kind of stuff. So those are really important things to think about as you're moving forward or looking at helping the substance use population. And being aware of what's happening at the national level. That's a lot. The national level informs a lot of how we're going to operate in the states and at the local levels. And every time terminology changes at the national level, it's going to trickle down until it finally reaches the community action agencies and some of the local agencies. So where a lot of people are using substance abuse or addiction or dependence, where we've moved at the state level to substance use disorder, and now at the federal level, they're even moving into more substance misuse as opposed to substance use disorder. So they're looking at it from yet a different perspective than we are. So it's constantly changing and evolving, just like everything else. More often than not, when you're working with clients with complex needs, we stumble across some of our own deeply buried experiences that can influence how we interact with those clients. At least if we are aware of some of those, we can be prepared when they pop up during interactions with our clients. One of my best examples is when I was a young person, early teens, my mom worked in a group home for people with intellectual disabilities. And she was a resident manager, so we would have to live there like 3 or 4 days and then back at home 3 or 4 days, and that was kind of our cycle. And just the constant interactions and the additional health requirements that we had to go through to ensure that we weren't going to accidentally get, for instance, hepatitis A, hepatitis B, any of those kinds of things, really informed me that I knew that that wasn't a population I wanted to work with as an adult. And yet, when we were working with people with substance use disorders, we do get some of that crossover where we'll have clients with intellectual disabilities. So I have to be very aware of some of my own deeply buried experiences that I had as a young person growing up, and not put that on the clients that I'm working with. And I know that that's not a population I can work with, and everybody needs to give themselves an out, that if there's a population that you know you can't handle, that's okay. You know, understand that and recognize that you just can't do that, and somebody else will be able to cover that need. recognize your limitations and the limitations of your staff. Focus talents to where they can be most maximized. Person-first language. That's one of the big things that we emphasize both in mental health and in SUD. We are working hard on that with primary care. As most of you probably know, we don't call people diabetics or epileptics or any of that kind of thing anymore. We use that person-first language, and we say that they are a person with diabetes or a person who has epilepsy or a person who has a substance use disorder, a person who has a mental health disorder. So that's part of that person-first identity and moving away from identifying somebody as their problem first. People in recovery from substance use and mental health disorders have done a vastly amazing job of explaining to professionals in the field that referring to them as addicts, schizophrenics, borderlines, alcoholics, reduces them to their disorder and leaves out all the really important parts of themselves. And that just kind of emphasizes to them that they're a problem as opposed to a person. So they have been able to help the people that they're working with understand that by doing that, they're leaving out the qualities that make those people feel positive about themselves. And then that kind of leads to some other issues of, you know, relapse and using again or stopping to take the medications and that kind of stuff. So we have to make sure that we refer to these, to our clients as people with a substance use or a mental health disorder, or people with a severe medical problem, or people with an intellectual disability, or a person with autism, that kind of thing. So I do a lot of work with special populations, and probably some of you do as well. I work with adolescents, transitional age youth. For us, transitional age youth are individuals who are 16 to 25. So even though somebody over 18 is considered an adult, in the substance use and mental health world, we know that brain development really kind of lumps them into a different category. Their brains have not completed development until around 25. And if they started using substances at an early age, that kind of stopped their brain development at that age. So if somebody started using pretty heavily at age 16, chances are when they stop using at age 24, 34, 44, they're still going to have a lot of those 16-year-old behaviors. And it can be very frustrating for people who are working with them because they're acting like a child, but they're getting adult interventions, and it just doesn't work. We have, in Michigan, been developing infrastructure to treat adolescents and transitional age youth with SUD treatment. We knew that this was a population that we weren't reaching very well. We had a really low contact rate with this population. About 8% of the individuals who identified as having a substance use disorder between the ages of 12 and 25 were actually getting services. And one of the things that we've discovered as a result of working with this population is they don't like being referred to as being in recovery. To them, it just seems like a lifelong sentence, that they're never going to have any fun anymore. All the things that all the people that are that age that they're going out and doing, they will never be able to do. They're never going to be able to go out to a party because somebody might drink or somebody might have a drug there that could trigger them into relapsing. So they don't really like that thought, and a lot of them have said that the thought of working at recovery for the rest of their lives is just too much. So they prefer to think of themselves as managing a disease, just like somebody with diabetes, just like somebody with epilepsy, just like somebody with autism. And this is even more in line with the whole disease model of substance use disorders, and even more than the professional field can grasp, they have managed to identify for themselves, which is pretty impressive when you think about it. And as I mentioned, mental health and SUD are constantly evolving fields. Just like the medical field, there's constant research being done, constant new interventions being reviewed and putting into our evidence-based practice repertoire of services that we can offer, and lots of new terminology. One of the special populations that a lot of states struggle with is the LGBT individuals. They have far more needs than any of our programs are really set up to provide for. Just being able to understand how somebody wants to be referred to, what use of pronouns to use with them, how to support transgender individuals, ensure that they feel comfortable in a group setting. All of those different factors make it really difficult even in our substance use disorder and mental health field. We have women who are LGBT and they're in a women's specialty program, but their issues are not the same as the other women in the group. And it's really hard for them to then identify with the rest of the population or get their needs met. So we've had to work really hard at connecting them with community action agencies who are addressing these problems, or their problems specifically. So they already have LGBTQ groups that they're doing. They already have some other therapeutic interventions that our programs don't have that we can connect them with. And then we pretty much serve them primarily with individual one-on-one treatment to address their substance use, as opposed to some of the group things that would identify different parenting issues, domestic violence, stuff that maybe they can identify with, maybe they can't. And we basically let them choose what's going to work best for them. Very often our LGBT clients have a very strong history of trauma. They've got very little family support, and they have relationship issues. So from the perspective of our providers, they have to be willing to accept whoever that client identifies as their family, because they have along the way collected the people that are close to them that they identify as their family. So even though they're not related by blood, these are the people who are providing the support, and so they are the ones who need to be included in that family therapy and in whatever referrals for services they receive through the community. Every state has specialized substance use services for women who are pregnant and parenting. These services are designed to engage women and their families, and whoever they define as family. The services are designed to meet all the complex needs that a woman who is pregnant or a woman who has children. They provide supports to them moving forward. They get them connected to those community action agencies that you all are involved with. The services to this population are based on relational theory, and there's a lot of very interesting information out there if you're serving women on relational theory. But basically, this talks about how a woman's relationships with the world around her are what's important to her. So you may have men in treatment or in your agency who will introduce themselves based on what they do, what their job is, as opposed to what their status within their family is. And that's how a woman thinks of herself first as a general rule, especially if she's a woman with children. She's going to think of herself as a mother, a daughter first, as opposed to somebody who works within a service setting, or somebody who works in a doctor's office, or somebody who is a cashier. So SUD treatment services for pregnant and parenting women are based on that understanding and improving those relationships and interactions. And as you probably already know, most of our substance abuse population have burned a lot of bridges as they've went through their addiction. And so by the time they get to us, they may not have a lot of those relationships. So our programs do a lot of work at repairing those relationships and helping families and significant others understand how they can be supportive without enabling somebody's disease. Every population, every person who provides services to their community can benefit from motivational interviewing. Depending on what kind of work you do, that might be something that would help you connect with your clients a little bit better. The basic classes are designed for pretty much anybody who interacts with clients. It teaches you how to be a better listener, how to let the clients start to work out some of their problems for themselves, put the client in the role or the position of power in the relationship where they're the ones leading the process as opposed to you as the professional or the person in the community agency who knows best. So they're a lot more invested when they're the ones who are kind of leading the charge, when you're providing them the support and giving them the information that they need to be able to go out and do what they need to do. So identifying needs. Probably a lot of you have already heard about active listening. Being an active listener when you're interacting with individuals means reflecting what they're telling you, listening instead of interrupting. You're of course allowed to take notes and that kind of stuff so that you're able to then provide for what they need, but it's really paying attention to what the client's saying and being present at that time. When I worked for Head Start, I always prefaced all of my interactions with parents as far as their children with, you are the expert on your child. I may know a lot about child development, and the teachers may know a lot about child development and what children generally at this age need, but you know your child, and so we need to learn more from you about your child. And that always helped parents make a better connection with us and be a bit more open about some of the needs that their children may have or some of the things that they had experienced in their young lives. And then that helped us help the families. Most clients are going to be able to tell you what they need if we're able to listen for the clues. Some clients are going to be really closed and never give anything away, especially not intentionally. But if you're a good listener, a lot of times you can pick up some of the cues that would lead you to the better understanding that, hey, they might have some trauma in their background. They might need some services for that, as well as the services that they came in for, whether it's housing or employment. So if you've got a client who's constantly in crisis, constantly struggling, they're never able to follow through or grasp the information that you're giving them, there's probably an unaddressed underlying issue. A lot of times, especially in the mental health and SUD world, we tend to take that as resistance. Oh, they're just not ready for treatment. They're not ready to do what they need to do. And they get dismissed from services without anybody ever realizing that there was a barrier, whatever that might have been for the client. In our world, a lot of times that tends to be we have an adult seeking services who has a fetal alcohol spectrum disorder that has never been diagnosed and never been treated. And so as they're moving through our services aren't designed to meet their needs. We have some services designed for people with a cognitive impairment. Sometimes that's enough for some of our FASD people, but sometimes it's not. And we have to realize that we have to be much more repetitive, do things a lot more slowly, and kind of go over the process repeatedly. We have to help them with planners and with reminders in their phone so that they show up for appointments. And that sometimes means that our receptionists and programs have to do reminder calls a couple of times in order to make sure that somebody is going to be there. We were trying to move away from those clients who would come in for the assessment, we'd set their appointments, and then they'd never show up again. So we knew that we had a problem, and it wasn't necessarily their problem, but our problem to manage and to help them manage until they could manage it a little bit better on their own. So I have a link here to some of the screening tools that a lot of different agencies use when they're looking at doing some screenings for substance use disorders. These are screenings that the average layperson can use. A lot of times child welfare uses them. Doctors' offices will use them. I think some of our WIC programs, the Women, Infant, and Children's programs, use them. And they're free, and they're fairly easy. And they give really good instructions. Hey, if you had a positive answer to 2 questions, that means somebody might have a substance use disorder and they might need to be referred for services, and then that can help you get them to where they need to be. Some of those tools are the T-ACE, which is T-ACE, the CAGE, the Audit, the CRAFT, and CRAFT has 2 Fs, and that's for adolescents. But if you're going to use these screening tools, just like the doctors, you'll need to have a knowledge of the resources that are available in your community to connect people with services if they do need them. And I think there will probably be a better opportunity during the follow-up call for me to, if you have specific questions about who provides services in your area, I can connect you with your state agency and they can give you a better idea. But making those connections with your state agency is really important. If you don't have any other resources for finding substance use disorder services in your community. Every state is different, but most states at least maintain a list of their providers, and they can give you some guidance on connecting people to services. Michigan's system operates a little bit differently than a lot of the other states in that we have a subrecipient level. So we get all the money from the feds as far as Medicaid and other money from the Substance Abuse Mental Health Services Administration. And we pass that down to 10 agencies that manage all of the providers in our area. And then they'll contract with the providers, and they have set up what we call an access management system. So anybody who needs services can basically just dial a 1-800 number, and they'll get connected to a program. And that makes it a little bit easier for us at the state level, less for us to manage because we do have a lot of counties in our state. And we have about 375 providers in our publicly funded system. And we have a very small staff, so that would just be way more than we could manage at the state level. But our intermediary agencies do a great job. So when we happen to encounter somebody who has private or third-party insurance, whether it's like Blue Cross Blue Shield, an HMO, a PPO, that kind of thing, we don't have a really good idea of what providers they have. We do have some providers in common, but most frequently, when they interact with our system, we just have them call the number on the back of their card. And I always tell somebody, if they happen to get to me, call the number on the back of your card, find out some agencies that are in your area that can serve your needs, then call me back and I'll tell you if I know any of them and which ones might be the best. And I work with a lot of parents that way when they're calling for their adolescents who have a substance use disorder, because a parent is always terrified when they find out that their child has been using drugs or alcohol, and they, of course, want them to get the very best care they possibly can. And yet there isn't always a lot of information about programs out there, or what they find on the internet of all these glowing reviews, and then they get their child there and it's a far different program. So I try to be aware of all the different programs for them, and I can give them some pointers. And most of our agencies do that as well. Some of our community action agencies in our state maintain a resource book or a guidebook for parents, and they just update that annually. That works really great. We've also done a lot of development in Michigan around our 211. That tends to work pretty well. Not every area has it. The more rural they get, the less likely they are to have that, which is ironic because that's really where they have a deficit of services, and it would be very helpful. A lot of our 211s are funded by the United Way and through grants with them. And as I mentioned in the beginning, we're all very used to working in our own silo, but we really have to get better at working together, becoming more aware of what others are offering if we want to be able to serve this client population effectively, and we want to make sure that all their needs are met and they're going to be able to be successful. Our collaboration in Michigan tends to go in waves, and it's usually motivated by a need. So the fact that we have this huge opioid epidemic going on now has created a new wave, and it's a new wave in every single state. A few years ago, it was the methamphetamine crisis that people were dealing with, and that was another wave, an opportunity for all these agencies to work together. Some of the other ones that would be more health-related, crisis with teen pregnancies. In Michigan, we have kind of some ups and downs with stillbirth, successful pregnancies, full-term pregnancies, that kind of thing. And all of that kind of contributes to the willingness of different agencies to interact better together and to maximize our funding streams. a few years ago in Michigan when we became involved in the nationwide child welfare lawsuit and subsequent settlement. That was a wave that prompted child welfare to become a better partner, be more open, have a better understanding of the needs of parents, whereas prior to that they had focused solely on the child and making sure that the child was safe, and removing the child from a family or leaving a child in a family without really having a good understanding of what that family was going through. And then that led to a significant amount of issues in Michigan. Child deaths, child abductions, and we suddenly had a massive population of orphans, over 8,000 children in our child welfare system whose parental rights had been terminated. So we've had to work really hard to be better partners, to be more understanding of what's going on with our client population, and to be more patient with each other as we're all trying to learn what's going on in the other system. So as I mentioned earlier, I'm going to talk a little bit about confidentiality of substance use disorders. The 42 CFR Part 2 is what governs confidentiality for SUD. It has recently been updated, but not drastically. So most of this went into federal law 30 or more years ago. And the main concern at that time was that a person who has SUD not be treated any differently than a person who doesn't have SUD. So it was really important to the legislators at that time, and there was a lot of strong advocacy on the part of Alcoholics Anonymous and some of those groups, that individuals with an SUD or who had alcoholism or who had an addiction, that they be able to move through other systems, medical, community action, whatever it might be, criminal justice system, without that stigma, because there was a big stigma back then. If you were a person who was considered to have alcoholism, you were treated very differently. That's gotten a lot better, and part of the reason is this confidentiality issue. We run into problems with this in Michigan when we are working with child welfare, when we're working with law enforcement, because the standard of confidentiality is so high, and it's higher than HIPAA, that a lot of times we're not allowed to share any information. And our clinicians who are working with our clients are so afraid of violating a client's confidentiality that they've kind of gone the opposite way, where they are really cautious and won't share anything. So we've worked really hard with our judges, our family court system, to help them better understand that, yes, we are more than willing to cooperate and provide what you need. As long as the client will sign a release for us, we'll provide you with reports. If they don't sign a release for us and you want to subpoena us, that's great, but a subpoena has to have this certain language in it that's included in the 42 CFR Part 2. Most judges are completely unaware of that. Most attorneys are completely unaware of that. And so a lot of our programs will randomly get a subpoena that they can't respond to, that they don't show up in court for, and then we're seen as being resistant, of course, that we don't want to help, that we're secretive, that we're hiding a client's problems, that the client has more problems than what they're aware of. So it's kind of a vicious circle, and we've tried really hard to make that better so that our clients can get better service. Let's see. So if you are working with a client who is in SUD treatment, or that you're referring to SUD treatment, try and make sure that you get a release of information signed. And you can always contact the program that you're referring them to and just ask for one of their standard release forms, have them fax it over to you, and while the client's there, you can have them sign it and fax it back over to that agency. Otherwise, the client might leave your agency, go to the treatment program. They may never sign that release of information, and you'll never have any information on if they aren't making any progress, if they even showed up. And SUD has a very certain release form that has certain things covered, so a lot of the standard release forms don't always cover what we need to have covered. In Michigan, we have that form just readily available on our website. We have just a generic standard form that any of our agencies can use and any other community service agency can use to be able to communicate better with our substance use disorder agencies. So I have my contact information here, and my best advice to you guys as a community action agency is you probably know or you can find out what your community's deficits are. Then find out if that's a need that you can fill. We're always looking for, as a substance use disorder provider and as a state agency, those agencies that can meet the deficits that we have. We don't want to have to create new programs if we don't have to. We're thrilled when we find somebody who's already doing something that meets a need that we can't meet through our own agencies and programs. So that's one of the last things that I want to leave you with, and I'm happy to answer any questions that you might have.
All right, well, if anybody has any questions, go ahead and send them into the chat window. You can send them to all panelists would be the best way to do that, so that both Angie and I can see them. And just as people might be thinking about any questions, I had one kind of going back to whenever you were talking about the telehealth that you all are doing, and you have the relationship with University of Michigan, and I know you talked a little bit about being able to find those partners to do, to collaborate with. But can you talk a little bit about how that relationship with the University of Michigan developed that might be helpful for other states or local communities if they were to contact their local universities?
Sure. So we are blessed to have many universities throughout Michigan that are really quite stellar. They do a lot of research, they do a lot of community outreach, and they are willing to be partners if they can do additional research. So one of the ways that we have appealed to them over time is by saying, hey, you know, you've done really well, like with this MC3 thing with the child psychiatry, and we would like something similar for individuals with an opioid use disorder and helping to serve those doctors. Do you think that that's something that you guys could manage? And they jumped at that opportunity because they also know that we're having an opioid epidemic. And especially because U of M has a med school, in at least, you know, with this particular university, they have a med school. And they know that they are turning out doctors who have no idea about substance use disorders or really about prescribing appropriately. So they've been doing a lot of their own research independently on a lot of that type of surgery, prescribing, continuing education for their physicians as they're leaving. So they are really willing partners right now with basically anything that we ask. And Michigan State University is the same way because they also have a med school. So it's kind of identifying what a university specializes in, what they're already researching, and then presenting them with an opportunity. And, you know, if you can give them money, as they always say, you have to publish or die and bring in grant money. So that's basically how you have to approach the universities.
Sure. Okay. Thanks. That's helpful. All right. I'm not seeing any questions come in at this point.
Okay.
So I'll go ahead and kind of proceed through kind of our conclusion slides. But if anybody has any questions as we're wrapping up, please do type those in. And then we'll have a further opportunity to engage during the subgroup call, which I'll talk about that in a moment, but it'll be on July 10th. And would love to talk to some of you all that are on the line about the substance use disorder kind of programs that you guys are running and what ideas you guys are having or obstacles or successes, anything like that. Because sharing those best practices with each other can often help to better serve the families and communities. So I know that I learned a few things from listening to you today, Angie. You know, I wasn't aware of the new terminology as far as, you know, the whole beginning part of the webinar I was saying, you know, talking about substance abuse, but knowing that substance use disorders is now the correct term nationally is very helpful, and learning all of those strategies in working with clients and working with other community partners around confidentiality is very helpful, because I know that with community action, you know, we're kind of implementing a new nationwide performance management system through a new annual report. And so one thing that is going to be a little bit more important moving forward is a little bit more of that follow-up piece. And so sometimes that is a huge obstacle to be able to get that information back after you've made a referral. And so knowing that, you know, you can contact that you know, agency that might be providing treatment and sign off on that confidentiality form at the very beginning to help facilitate some of that follow-up is very helpful. All right.
My pleasure.
Yeah. So looking at some of our upcoming meetings that we have our, like I said, the Health and Substance Abuse Subgroup Call on Monday, July 10th. So encourage you all to join in that. Let us know what you're doing around this topic, and let us know, you know, what kind of resources we could help you with. Even in the meantime, if you think of things that would be helpful specifically to kind of focus in on during this call, would definitely welcome that input. Then, like I mentioned earlier, we are going to be having our next and actually final for this iteration of Learning Communities for the health intersections, the health and food and nutrition. So we're going to have Dr. Charlie Homer from the Harvard School of Public Health, as well as two pediatricians, one from Boston University and another one, Dr. Anand. And so they're going to be talking about food access, access to healthy food, as well as some of the federal supports around food access also. So we're going to be highlighting a couple of community action examples during that, and then getting some information from these professionals. So that should be a good topic coming up. So just to let you know where all of our resources and follow-up information is housed, we have a Basecamp site. And so anyone who participated in this webinar, if you haven't participated in a previous Health Intersections webinar, I will add you in the group. So then you'll have access to the slides, the recording. You can have conversations with your peers in the discussions, and be able to connect that way. So this is just kind of a picture of what it looks like. It gives you project updates, and we give reminders for the upcoming webinars on there as well. We also have a Learning Community Resource Center blog, and so you can go to lcrcweb.com and you subscribe to it, and you'll receive regular updates so that you can follow the blog. We post additional resources on the blog, as well as the follow-up resources from the website, or from the webinars, pardon me. And you can kind of get a picture of what other learning communities that we have that you might be interested in looking into. So the 2017 annual convention for the partnership is also coming up. We always like to do a plug for this in case you're not aware. So we're going to be in Philadelphia this year, August 29th through September 1st. We have over 90 sessions that we're planning to help build up the network and provide some good learning opportunities. So if you haven't registered, you can register online. You can just go to our website at communityactionpartnership.com. And under the Events tab, there's a space to find out more about our annual convention. So then the Learning Community Practice Transformation Mini General, a little bit of a mouthful, but we're going to be doing a mini general around some of the outcomes of the learning communities. This phase of the learning communities is wrapping up this summer. And so we're going to be kind of showcasing in some brief 5-minute presentations what has gone on during the learning communities in the last 2 years. And so this should be a good way to kind of get a sense of what the purpose of the learning communities are and what the benefit can be. And then we are in the process of working to launch another iteration of the Learning Community Resource Center. So stay tuned for more information on that. All right, and then just kind of in conclusion, if any questions for the LCRC staff, feel free to contact us. I put a few of us on this slide. I'm Courtney Kohler, the Senior Associate down at the bottom, but feel free if you know some of the others, you can reach out to them as well. I will check the chat one last time just to double check. And we didn't have any questions come in, but we appreciate you all being on the call today, and thank you again, Angie, for everything that you provided today. And we'll go ahead and sign off. So we'll be providing all of this information towards on Basecamp and Learning Community blog at the very end. So thank you all. Appreciate your time. Have a good day.